Hello, good morning. Today we will talk about our role, occupational therapy, in rehabilitation post-rest fractures. And if we talk about rest fractures, it will also apply on distal radius fracture, distal ulnar fractures, which is really common in pediatric school setting, in football, in MVAs. Our role is really huge, and it's very important and essential to prevent rest stiffness. So initially, many doctors doesn't prefer to splint the rest again after removal of cast. Some others, especially with young ages, with the first movements you will do with the patients. I know early exercise is very essential, but always good to start your session with some skin care, and then you can start your range of motion. So the best to start with contrast bars are very good in dealing with patients. Number one, it stimulates the blood circulation in the area. It fastens healing as well, and it reduces edema. So you need to wear a cock-up splint, a circumferential one, mainly like in a school setting for young patients, just to protect the fracture area, especially if the healing is not 100%. So before starting exercises, you need to look at many issues post removal of cast. Number one, skin. So always patients will report with dry skin, excessive hair growth in the area, some mild edema as well in the area. So skin care is very important. Sometimes they have pain as well, especially with the first. Have 2 bars of lukewarm water, above lukewarm a little bit, and then you can have another bar with ice water. And then you can start. I know our patients always prefer to start with hot, but better to start with cold container. 30 seconds in each container will be good. And then you can encourage patient to do some gentle movement for the rest inside the hot water especially. So we'll have a look at the contrast bars. And so this is the lukewarm water, and this is the tap water. I'm just adding some crushed ice. You can tell patient first that this is really cold, and then you can try it also with your hand. And then slowly, patients could put his hand down. So the water should be 3/4 of the container, so it will reach at least middle of the forearm. You can get it around all the dry skin as well. So the dry skin will be melted, and then you can easily get rid of it. Then like 30 seconds, and then patient could move to the lukewarm water. Okay, Marlon. So once the tube grip is there, you will ensure that patients will be comfort during the exercises. So you can start grasp and release. Okay, can you do it? Like for 10 repetitions. And then patients, we used to tell patients, nice to repeat exercises after each pray. So it will be a very good reminder for them. Once they pray, they do the exercises. So we're not gonna do any resistance exercising for the first week, post removal of cast. Mainly release till 2/3 of the forearm, and then you can double it, like 3/4 of the space. You can double it, and then you can leave 1 centimeter, and then by another 1 centimeter, and then make a cut. So this will be for the thumb area. Cast, mainly range of motion. So grasp release for 10 repetitions, then thumb opposition, and then get the tip of the thumb to the base of the little finger 10 times as well. Then you can do some lateral deviation, like some lateral side to side, very gently. Will be a bit painful than grasp and release. 10 times as well to each side. Cast, mainly range of motion. So grasp release for 10 repetitions. Then thumb opposition, and then get the tip of the thumb to the base of the little finger 10 times as well. Then you can do some lateral deviation, like some lateral side to side, very gently. Will be a bit painful than grasp and release. 10 times as well to each side. And down. Yes. As we mentioned, if the healing is not 100%, we can immobilize the rest only in doing heavy duty work, or if you have a student during school time, because usually this is the age. I just need to do the opposite way now. Extension. Okay. Can you pull up? Yes. Ten times as well, and then lateral. Okay, up. So a cock-up circumferential splint is good to apply. As we mentioned, mainly during heavy duty work, school time, just to protect the fracture. And then patient should remove it once he's resting or he's at home, so he can use his hand normally in the ADLs. And then you can of course add as OT a lot of functional activity tools. You can use it as well with patients. I would like to thank Marlon, my patient, and I would like to thank Sheikha Al-Madkhali for videoing the intervention.